All right. So this is the last lecture of the semester, because next week we will have the week off, and then for Thanksgiving, and then the last week you will be doing presentations. So what we're looking at in this unit are late somatic effects. We know that when radiation exposes an organism, human, whatever, that radiation deposits energy into that organism. And radiation interacts either in ionizations, which are 80% of the time, or excitations. Now, in the general diagnostic range, the ionizations are photoelectric and Compton. Those are the two processes. Which of those processes is true absorption?
Photoelectric.
Photoelectric. And what is Compton?
Scatter.
Scattering. So both photoelectric absorption and Compton scatter are ionizations. And they are the two most prevalent interactions that occur in the diagnostic energy range. So when they interact with the patient's body, that energy exchange is immediate. However, the biological response may not be seen for many months or even years. So those would be the late effects. And so that's what we're going to talk about predominantly here. Now, when we think about the exposures, we know there are all different types of exposures. When we are exposing a patient for an imaging exam, that would be acute low-level exposure. The exposure is given all at once, but it's a small dose. And it's also a partial body. We don't expose the patient's whole body. We expose only a specific area. As occupationally exposed personnel, we are exposed to chronic low-level exposure. So we're exposed over a long time, but to a very, very low level of radiation, only from scatter or leakage. Then we can have acute high-level exposures, such as would cause the acute radiation syndromes. So that would be a large amount of radiation all at once. And all of these different types of exposures can result in biological effects. Some short-term, some long-term. We can also categorize biological effects according to whether they are somatic or genetic. So somatic effects we know occur in the individual exposed. We have an example here of a person whose hands were exposed to a high level of radiation. They have radiodermatitis. That's a somatic effect. The individual was exposed, they have the effect. Genetic effects are seen in future generations. Genetic effects can result from either high or low level radiation, and it results when the reproductive cells are changed or mutated, and those reproductive cells are used in conception. We can describe biological effects as short-term. That means we're going to see them within a few days or up to a few weeks after exposure, or they can be long-term, which means they may not be seen for many months or even many years. We talked about in the last class the acute radiation syndromes. Those are short-term effects or acute effects. The things that we'll talk about today, like I said, are long-term effects. Also, to review some terms that you've heard many times, so you should be familiar with these. Somatic effects can be described as stochastic or non-stochastic. So stochastic effects are based on mutations. The primary stochastic effect is cancer induction. They are considered non-threshold, so we consider that any amount of radiation, even a single photon, has the potential to cause this effect. However, they are also probabilistic, so they're based on probability. The probability of the effect occurring increases as dose increases. So even though one single photon could potentially cause cancer, it's not likely to, because it's such a small amount of radiation. So the higher the dose that a person receives, the greater the likelihood of cancer induction. However, if a cancer was induced by radiation, it doesn't matter if it was caused by a single photon exposure or a 10 million photon exposure. It's not going to influence the severity of the cancer. The severity of the cancer is not going to be modified by the dose that created it. The cancer is just the cancer. So then we have non-stochastic effects, also called deterministic effects. And I think now they're leaning toward calling these just tissue effects. Now, these effects are based on cell killing. They do have a threshold. So if a person is exposed to a level of radiation below the threshold, they're not going to see the effect. You have to receive enough radiation to get to the threshold before the effect will be seen. Since they're based on cell killing, the higher the dose, the more cells are killed, the worse the effect. So examples, common examples are from skin, because they're easy to visualize. So skin burns, which would be erythema, epilation, which is hair loss. Cataract induction is also an example of a non-stochastic effect. So if we look at dose-response relationships for the stochastic or for the stochastic effects, excuse me, which would be cancer induction, that's the one that we are most concerned with. They follow a linear non-threshold dose-response relationship predominantly. And so which curve illustrates that linear non-threshold dose-response relationship?
One.
That
blue one.
It graphs as a line and it begins at 0. Now, there also research that indicates that some cancers follow a linear quadratic non-threshold dose response. And we don't have a linear quadratic on the graph, but it would simply be it would start at 0 dose because it's non-threshold, but it would be curved at the bottom, more U-shaped before it extended into a straight line portion. Sorry. So the most commonly accepted dose-response relationship is linear non-threshold, but there are some cancers that they estimate to follow linear quadratic non-threshold dose-response relationships. For the non-stochastic effects, they are nonlinear or sigmoidal, meaning sort of S-shaped, and threshold. So if we look, that would be curve 3. It doesn't start until we're a certain way up the dose axis, so that's the threshold. Once we pass the threshold, we start to see the effect. The effects get worse and worse and worse until we basically have killed all the cells and it levels out, so it can't get any worse. So this is a nonlinear threshold dose response relationship. So non-stochastic or deterministic or tissue effects commonly follow this dose-response relationship. So any questions about stochastic versus non-stochastic effects or their dose-response relationships? Everybody clear on that, or anybody need anything clarified? We're all good? Okay. All right. So what we're covering primarily in this unit are long-term somatic effects. So we're going to briefly look at embryological effects because we've already looked at them in another unit. Then we're going to look at cataractogenesis or cataract formation from radiation exposure. We're going to talk briefly about lifespan shortening, and does our job put us at risk for a shortened lifespan? And then lastly, we're going to talk about carcinogenesis, which is cancer induction. And that's where we'll really focus most of our time. So embryologic effects. Now, we've already discussed this in a previous unit, but embryologic effects are considered late effects because after an in utero exposure, you may not see the effect for several months until the child is born. So we know that embryological effects are determined by not only the level of exposure, but the time period in which the exposure occurred. At very high levels of exposure to the embryo or fetus in utero, an exposure, when I say very high, we're talking about a 2 gray exposure, which is way higher than any diagnostic procedure we would ever do. But that large an exposure in utero, if it is during the pre-implantation stage, so those first basically 10 to 12 days of the pregnancy, 80% of the time it's going to result in a miscarriage or a spontaneous abortion, so prenatal death. The child will die in utero. Many mothers at that point might not even realize they were pregnant. If irradiation occurs during the second part of the embryonic stage, that is major organogenesis, a high level exposure at that time basically causes congenital abnormalities in every fetus. And the abnormality seen is the organ system that was developing at the time of exposure. 65% of the abnormalities will be so severe that they result in neonatal death or death in childhood. So the embryonic stage, we've already said, is the most radiosensitive time in the lifespan of any organism, and a high level radiation exposure during that time can have severe consequences. Once you move from the embryonic stage into the fetal stage, which is basically the second and the third trimesters, you note that structural abnormalities fall drastically, and you would be predominantly looking at functional abnormalities, meaning basically decreased muscle coordination, decreased intelligence, those sorts of things. So when we look at in utero exposure, again, to high levels of radiation, there can be severe consequences, but the consequences depend upon the time of irradiation as it relates to the gestation period. The earlier in the gestation period, the greater the consequences, because at that time, the embryo is a mass of simple cells that are rapidly dividing and they are poorly differentiated. So that according to the law of B and T, that would indicate that they are highly radiosensitive. Another risk of exposure in utero is childhood leukemia. And we'll talk more about childhood leukemia later on, but that is the one specific type of cancer that is associated with in utero exposure. Okay, so the second of the long-term effects or late effects is cataract formation. And cataracts are basically cloudiness of the lens of the eye. So if a person has cataracts, their vision is going to be diminished. Well, radiation-induced cataracts cause the same type of thing, but obviously aging is not the cause. The cause is radiation exposure. This effect was found predominantly in nuclear physicists who were experimenting with cyclotrons, which are particle accelerators, and also atomic bomb survivors, and some radiation therapy patients where the eyes were in the field of view. So cataract formation follows a nonlinear threshold dose-response relationship, which is basically similar to other somatic effects. Its threshold for an acute exposure is 2 gray, but for a fractionated or a longer term exposure, 10 gray. And it's important to note that radiation-induced cataracts are very uncommon. So this is not an effect that has been seen broadly. The latent period is quite long, anywhere from 5 to 30 years, with an average latent period of 15 years. So for the radiation physicists, they were working with these cyclotrons. Many of them did not develop cataracts until a long time after that. So average 15 years. One other thing to note is that for cataract induction, the radiosensitivity is age dependent. So the older you are, the greater the likelihood of having this effect. And for some reason, neutrons and protons or particulate radiations are more effective at producing cataracts than the other types of radiation. So radiation-induced cataracts, this is, like I said, it is a somatic effect. It is non-stochastic or deterministic, however you want to describe it. But the good news is this is an effect that's rarely seen. Okay, the next late or long-term effect that we look at is lifespan shortening. So when you enrolled in the program, when any of you enrolled in school, did any of you think that this career path might decrease your lifespan?
Nope.
Nope. Me either. And the good news is this is not something we really have to worry about. And we'll talk about why as we go through. Obviously, you can't experiment with humans. That would be unethical. But they have done experiments on laboratory animals, rabbits specifically, that have proven lifespan shortening from radiation exposure in small animals. And in those experiments, the lifespan shortening followed a linear non-threshold dose-response relationship. The question is, can we extrapolate the information from these laboratory studies in rabbits and probably mice as well to humans? And the answer is, well, we don't know, but we'll look at some history and see what has happened. So there have been populations studied relative to lifespan shortening. And the first were the early radiologists. And when I say early, many of them were not even called radiologists at the time, because these were just the doctors that worked with radiation, in the early part of the 20th century. And what they found is that in that early part of the 20th century, you can see that there is a difference, about a 5-year difference in the lifespan of radiologists and the general population. And that difference persisted up through the 40s, up to about the mid 40s. But then, as you went into the 50s, you notice that the lifespan of the radiologists started to increase. So we see that now the gap is getting smaller and smaller until the 1960s. And in the early 1960s, the radiologists had caught up and actually were living longer than the general population. So early on, when they weren't using proper protection, yes, there was a difference in the lifespan of radiologists compared to the general population. But recent studies have not shown that. They also looked at the World War II radiologic technologists, and these early technologists, again, who did not have the protection means that we have today. There was also some decreased lifespan in those technologists. There is an ongoing study. It's the United States Radiologic Technology Study, which has studied technologists over the last, well, at least 30 years. And they survey every 5 to 10 years to look at technologists, to look at what health concerns they have. And what they've determined is that current technologists typically are healthier than the general population. They also looked at the atomic bomb survivors to look at shortened lifespan. And the evidence has been inconclusive. So when they look at lifespan shortening, one of the things they looked at was, well, what are we talking about? Premature aging, or are we talking cancer induction? Are those the things that will shorten the patient's life? They've come up with a conclusion that the experiments on the laboratory animals cannot really be extrapolated to humans. And at worst, humans could expect a reduced lifespan of 10 days per rad exposure. That would be 10 days per centigrade exposure. If you want to put this into perspective, I have had a 40-year career basically in imaging. My cumulative dose, according to my dosimeters, is less than a third of a rad. So if you sort of extrapolate that back, maybe my 40-year career will have reduced my lifespan by approximately 3 days.
Oh, no, I need them 3 days.
I need those 3 days. You know, and it's an estimation. There's no way really knowing that. But anyway, I don't think you have to worry about your career shortening your lifespan. The statistics here that are on this table, this is just another study that compared the age at death from radiologists, and this was the ear, nose, and throat otolaryngologist, and these were pediatricians, I think. And from 35 to 44, the radiologists were much shorter. 45 to 54, it was a little bit shorter, and 55 to 58, it was catching up. So this was the time period when more protection mechanisms were being put in place, and so the radiologist's lifespan was increasing at that time. I think there's like I said, I think there's a lot more to worry about than our occupational exposure. So let's look at this chart. So Chad and Marcus, I hate to tell you this, but on average, just the fact that you're male means you're gonna live 2,800 days less than the rest of us.
Oh,
man.
Isn't that terrible? So, but if you look at that, 2,800 days, that's a lot. That's 7 2/3 years. So just by being a male, you have a decreased lifespan. If you have heart disease, 2,100 days. If you're not married, so everybody, if you're not married, go out and get married, because that will, if you don't marry, that decreases your lifespan by about 5.5 years.
I don't know, Don. They said it's the other way around. If you marry, it decreases it. I don't know.
Oh no, if you're married, you have somebody to grow old with. So,
or they stress you out.
oh, that's true. I didn't say a bad marriage. Maybe it could be clarified as a good marriage.
Yeah, if you're in a good marriage, that helps you out because it lowers stress.
Yeah. So if you smoke, we all know smoking's bad for you. So smoking 1 pack of cigarettes a day decreases your lifespan by about 4 1/3 years. And I'm actually surprised it's that little. If you're a coal miner, obviously there's risk to coal mining. You have risk of the dust diseases. Well, what's the term for the dust diseases?
Asbestos.
Now, asbestosis is one, but what's the general term?
Black lung.
Nope. They're the pneumoconioses.
That's what I said.
Not hardly.
I thought that's what you said, Chad.
Yeah. So if you are a coal miner, you're going to breathe in coal dust. So then obviously that's going to give you lung disease. Look at this. If you're 30 pounds overweight, that cuts nearly 3 years off of your life. Accidents, all different accidents, or just driving a car, motor vehicle accidents, 200 days off your life. So the whole point.
Now, I don't understand that one. I don't understand the accident one. What do you mean? What are they saying?
In general, motor vehicle accidents can cut 200 days off your life. Maybe they don't kill you, but they injure you.
Oh, okay. Okay. All right.
So look at where we are on the scale. Radiation workers. So we're grouped collectively with all other radiation workers. So the risk of lifespan shortening because of our occupation is approximately 12 days.
So that's not right then, because you just told us we talking to a real in-person worker, and she said 3 days.
Well, I said based on my exposure. This is like a ballpark.
Well, I'm going off that, yours, because they too high.
Well, here's the thing. If you have a higher level exposure than I do over your career, then you would expect to lose more days. If you had a lower exposure, you would expect to lose fewer days. From my perspective, I'm not worrying about it. You know, I've had a wonderful career. I've protected myself. You know, I don't think I have to worry about the risk relative to other things. There was a higher risk for me driving to campus and back every day for 40 years than there is from the radiation exposure.
I would agree.
Everything in life has risk. So, you know, are we worried about the risk from our occupation? I'm not. You know,
Me neither.
is up to
I'm worried
you.
about 30 pounds. I mean, who doesn't fluctuate between 30 pounds and what they like to be? I mean, I'm worried about that.
Well, here's the thing. You just have to make as good choices as you can and try to live a healthy life and hope for the best. That's sort of my take on it. Oh yeah.
Marcus is so tall, all of the radiation's just gonna go to his knees and his legs. So you'll be fine, Marcus.
I never thought of that.
Yeah, Marcus, it's gonna miss you, dude.
No.
You're good.
But anyway, I think we're all pretty good relative to lifespan shortening from the radiation exposure that we would receive due to our job. Now, we might have additional medical exposure that would cause issues, but mainly I think we're fine. All right. So now we come to cancer induction or carcinogenesis. And carcinogenesis from radiation can occur from any type of exposure, whether it's chronic exposure, acute exposure, high level exposure, low level exposure, because cancer is a stochastic effect, which follows that linear non-threshold dose-response relationship. The other thing to know is that radiation is a general carcinogen. And what that means is that radiation can cause cancer in any organism and in any tissue of that organism. It's also important to know that there really is no conclusive proof of increased cancer risk at dose levels below 0.1 sievert, which is 10 rem. So even though we say it follows that linear non-threshold or linear quadratic non-threshold dose response, we really don't have specific proof of radiation causing cancer at doses below 0.1 sievert. So since cancer is a stochastic effect, we consider it to be still non-threshold, despite what I've just said. The dose-response relationship is still considered to be linear non-threshold, although again, some say linear quadratic non-threshold or non-threshold. And the latent period for cancer induction is up to 30 years. So a radiation exposure today might cause cancer up to 30 years from now. Now there is some, I guess, disagreement among the literature and among reports. The Beer Commission, which is BEIR, the Biological Effects of Ionizing Radiation, In 1980, they reiterated the linear non-threshold dose-response relationship. And then they came back in 1990 and said, well, you know, in our last report, we really underestimated the risk of cancer induction. It's probably 3 to 4 times greater than we thought. So sometimes when you're reading these different reports, obviously they change over time, but sometimes it can be quite confusing. So what is the mechanism of radiation-induced cancer? How does radiation cause cancer? And the answer is, well, we don't know. Not really. What they theorize is that radiation interacts and produces mutations in the growth regulating genetic material. So on your DNA, the segments of DNA that control growth are changed, are mutated, and that results in neoplasia. So what does that mean? What is neoplasia?
Tumors.
It literally means new growth, which is, you're right, tumors. They could either be benign or malignant, but when we're talking about cancers, we're talking about malignant tumors. So it's like the normal controls for the development of your cells is changed and it goes a little haywire. So we know that cells should divide at a certain rate depending on the cell type. Well, when we have cancer induction or neoplasia, malignant neoplasia, how do cancer cells act in terms of cell division and differentiation?
They divide fast.
Okay. And are cancer cells as complex or as differentiated as normal cells?
I would say no, they're not.
They're not. They are not. So if we think of the law of B and T, law of B and T says that rapidly dividing, poorly differentiated cells are more radiosensitive. That makes them more easily killed with radiation, which is why radiation therapy works. So if we're talking about a radiation-induced cancer, a person is exposed. It's theorized that the radiation changes the growth regulating mechanism in their genetic material. That causes the normal cells to start to divide more rapidly and to digress or resort to a simpler phase. So they're going from a high level of differentiation to a lower level of differentiation, and their mitotic rate is increasing. So cancer cells, since they're more rapidly dividing, more poorly differentiated, then we could treat them with radiation therapy. So anyway, we don't really know why radiation causes cancer, but this is what has been theorized. So how can we link, since we can't do any controlled studies of radiation causing cancer, what is the link that we've seen in the past between radiation exposure and cancer induction? Well, there's actually numerous links. Nushin gave a report on the radiation watch-dial painter, or the radium watch-dial painters, excuse me. They absorbed radium. A lot of them ended up with sarcomas. uranium miners. Uranium miners breathe in radon gas. They ended up with lung cancers. The atomic bomb survivors, which were exposed to high levels of external radiation from nuclear attack, they ended up with all kinds of solid tumors and leukemias. And then the Thorotrast patients. Thorotrast was a contrast agent that actually had thorium in it, and thorium's radioactive. And so those patients ended up with liver cancers predominantly. So there have been a lot of populations that can make that link between radiation exposure and cancer. It would be much more difficult for an individual to say, I had a chest x-ray 15 years ago and now I've got lung cancer. That chest x-ray caused my lung cancer. Well, that would be a very difficult sell, because how would you prove that such a small amount of radiation at one time actually did cause their lung cancer? Because on an individual level, it's hard to make the connection. So we said that radiation is a general carcinogen, meaning it can cause cancer in all different tissues of all different organisms. Well, these are the cancer types that have most predominantly been seen. Leukemia, bone cancer, skin cancer, lung cancer, breast cancer, thyroid cancer, and liver cancer. So we are going to look at each of these and talk about some of the different populations that they have been associated with. So leukemias. So leukemia, we know, is a blood cancer, and several different populations have been linked to leukemia. The atomic bomb survivors, if they received a dose of 1 gray, the early radiologist, radiation therapy patients who were irradiated for ankylosing spondylitis. Anybody remember what ankylosing spondylitis is?
Isn't ankylosing spondylitis when it one of your bodies goes forward?
No, you're thinking spondylolisthesis. Ankylosing spondylitis is a condition, it's a type of arthritis, but it starts in the sacrum and the distal lumbar spine, and literally bony bridges build between the vertebrae. So it's like the entire spine is becoming encased in bone, so that the patient's going to lose flexibility, lose movement, and as it progresses, it's very painful. So at one point in time, radiation therapy was used as a palliative treatment, simply to relieve pain. It's not going to cure their condition. And those doses were anywhere between 1 gray and 40 gray. So high doses. And then of course, fetal exposures. We said that fetal exposures in utero can result in leukemia multiple years later. So all of these different populations that have been exposed to radiation have had documented cases of leukemia. The dose-response relationship is that linear non-threshold dose-response relationship. The latent period, the time between exposure and the leukemia, somewhere typically between 4 to 7 years, but they consider a 20-year at-risk period. The atomic bomb survivors had a relative risk of leukemia 3 times that of the general population. So a 3-to-1 relative risk. They were 3 times more likely to have leukemia than the general population. The ankylosing spondylitis patients, they had a relative risk of 10-to-1. So they were 10 times more likely than the general population to develop leukemia. So there is definitely a link between radiation exposure and leukemia. Bone cancers. And bone cancers typically are sarcomas. Now, the primary population listed, or when we think of bone cancers, we do typically think of the radium watch-dial painters. However, some atomic bomb survivors also developed bone cancer. Now, the radium watch-dial painters had a wide variety of dose levels, and dose levels anywhere from 2.5 to 500 gray are associated with bone cancers. And the radium is an alpha and a beta emitter. So we're looking at particulate radiations. In addition to bone cancers, osteoporosis was also seen, as well as cancers of the nasopharynx and the sinuses. That's because, think about the area of the face. They were licking the brush, ingesting the radium sulfate, and those are common sites. If you look at relative risk, the radium watch-dial painters' relative risk of bone cancer is 122-to-1. So they were 122 times more likely to develop bone cancer than the general population. Common sites of the bone cancer were, of course, the mandible, but also the pelvis and the femur. Okay, so next we look at skin cancer. And the 2 populations associated with skin cancer are the early radiologists, where obviously they did not take proper protective mechanisms, and then also some radiation therapy patients. Oftentimes the radiation exposure would cause radiodermatitis initially, and then in later years, skin cancer would develop. So the latent period was typically 5 to 10 years. And this is the one type of cancer that has a threshold dose-response relationship. The risk of skin cancer increases as the dose increases, but the threshold seems to be somewhere around the 5 gray mark. So skin cancer, the one cancer that does seem to have that threshold dose-response relationship. But like I said, if you look at dose levels between 5 and 20 gray, there's a 4-to-1 relative risk. If it goes 40 to 60 gray, it's a 14-to-1 relative risk. And 60 to 100 gray, it's a 27-to-1 relative risk. And it's not important that you remember all of these relative risk numbers. Just know that when you're comparing people who have been exposed to radiation to the general population, they show you that there is indeed a risk associated, a cancer risk associated with these radiation exposures. The next type of cancer that's been linked to radiation exposure is lung cancer. And the populations have been predominantly miners. The German pitch blende miners, and pitch blende is crystalline uranium oxide. So it's still a uranium product. And then the American uranium miners from the 1950s and 1960s. As uranium decays, one of the byproducts is radon gas. Radon gas is an alpha emitter. So these miners are in the mines breathing in radon gas. When they breathe in the radon gas, the alpha radiation literally just sits on their lungs, because remember, alpha particles don't penetrate. They're not going to move very far. Whatever surface they hit, that's where they're going to interact. So the radon gas alpha particles are literally just going to highly ionize the patient's lungs. It's estimated that the uranium miners, the American uranium miners, had doses or received doses in excess of 10 sievert. So that's a lot of radiation. But uranium itself is an alpha, beta, and a gamma emitter. But the biggest culprit is the radon gas, which is an alpha emitter. So altogether, dose levels of greater than or equal to 30 gray are associated with lung cancer, and it is that linear non-threshold dose response. Something that's interesting is that these uranium miners had a relative risk of 8-to-1. So they are 8 times more likely than the general population to develop lung cancer, unless they smoked. The uranium miners who smoked had a relative risk of 20-to-1. So it's like they compounded their issue by smoking. So it increased the relative risk from 8-to-1 to 20-to-1. Moral of that story is cigarettes are bad for you, and so is uranium mining.
I would say.
Yeah, really. I don't think I want to do either. All right, the next type of cancer that's been associated with radiation exposure is breast cancer. And I don't know if you remember, but from our imaging equipment class, when we talked about the history of mammography, remember that early mammograms were performed on film alone with a dose of about 50 rem per exposure. So the early mammographic studies exposed the breast tissue to high levels of radiation. Radiation therapy patients where breast tissue is in the field of view also have developed breast cancer. TB patients for many years earlier in the 20th century, they gave tuberculosis patients chest x-rays all the time. So those patients had a 10-to-1 relative risk of breast cancer because they got so many chest x-rays. The atomic bomb survivors also had increased risk of breast cancer, and they had a relative risk of 4-to-1 if they received more than 0.1 gray to the breast. So there's been a lot of different populations, again, that link breast cancer to radiation exposure. Thyroid cancer. Now, when you think of thyroid cancer and radiation exposure, the group that should come to mind should be the Chernobyl victims, because they are the most recent of radiation accidents or nuclear power plant accidents. Children who had enlarged thymus glands, they irradiated the thymus to shrink it, but the thyroid was right in the edge of the radiation field. So they irradiated to about 5 gray to shrink the thymus, and then a large number of those children developed thyroid cancer. I think it was Haley that talked about the Marshall Islands and the radiation exposure from nuclear testing. Well, those children who received approximately 12 gray from fallout from nuclear testing also ended up with thyroid cancer. And then, of course, the Chernobyl victims and the Chernobyl nuclear power plant accident, where the fallout was spread over Europe. And the fallout fell to the ground, the cows ate the grass, gave the milk, people drank the milk, so children were affected there as well. Also, the atomic bomb survivors did have excess incidence of thyroid cancer as well, but again, like I said, they had lots of different cancers. So thyroid cancer goes back to that linear non-threshold dose-response relationship. But again, all these different populations have shown that link between radiation exposure and cancer. Liver cancer, and it was not just liver cancer, it's cancer of the liver predominantly, but also cancer of the spleen and the bile ducts. And this group were the thorotrast patients who received a contrast agent during angiography that had thorium dioxide. It was 25% thorium dioxide. Well, thorium is radioactive, and it was concentrated in the liver predominantly. So why they used it, I have no idea. They knew it was radioactive. Apparently, they didn't think it would be a problem. But what they found out was that within a 15 to 20 year latent period, cancers of the liver were developed from this population. So, like I said, radiation is a general carcinogen. Any organ of any organism, and all of these different groups have proven that. So let's talk just a minute about risk. What is the risk of cancer induction from radiation exposure? Well, there's different ways of looking at risk. So we're gonna look at some different examples of risk assessment, and then I'm going to ask you to rate some things that you think are risky. But we'll start first with relative risk, because we've already talked about this, or we've already mentioned this when we were talking about the types of cancer. The relative risk is found by dividing the number of observed cases of cancer by the number of expected cases of cancer. So basically, if you had a population where normally you would have 10 cases of cancer, that would be how many you expected, but all of a sudden you have 15 cases, then you could calculate the relative risk. So it's comparing how many people have the cancer with a number that you expect to have it from previous data. Now, if the relative risk is equal to 1, that means there was no risk at all. So if we expose a large population to radiation and the number of people with cancer were exactly what we expected, then that would mean that there was no risk from that radiation exposure. If the relative risk is greater than 1, that means there is some risk that radiation exposure caused some cases of cancer. If the relative risk were less than 1, that would mean that the radiation was beneficial. Radiation hormesis. I don't really know of any cases where that happens, but that would be the way that you would look at it. So typically, you know, like I said, relative risk is going to be greater than 1 from a large scale radiation exposure. But that's one way that we can look at risk. Another way that we can look at risk is in terms of excess risk. And that is simply by subtracting the number of cases that we expected from the number that we actually had. And that would give you the difference. So say if you expected 10 cases of cancer, but you had 12 cases in the population, the excess risk is 2 cases. So whatever radiation exposure was received caused 2 cases of cancer. We don't typically look at excess risk or use excess risk. We would typically use relative risk because that seems easier to understand. We can also talk about risk in terms of absolute risk, which is how many cases per million people per rad exposure per year could we expect? And this is very complicated and it's very difficult to explain. But in general, if we look at all the different sources of radiation exposure, we can expect 10 cases per million people per rad exposure per year. And that's 10 cases of radiation-induced cancer. And there is a 20 to 25 year at-risk period. And it does assume that linear non-threshold dose-response relationship. This would be very difficult to use when you're talking to the public because I don't know that they would understand what you were trying to tell them. I think relative risk would probably be the easiest one to explain. But here's some information, and if you ever want to look at additional information, you really should go to the Beer Commission reports. It's BEIR. So the Beer 7 report has a really good and simple explanation of risk assessment relative to cancer induction. And the example that they give says that if you look over the lifetime of 100 people, 42 people out of that 100 are going to develop cancer from whatever reasons, from lifestyle, from genetics, from environmental exposure, whatever. So in general, if you have 100 people, 42 of those people are going to be diagnosed with some form of cancer in their lifetime. That's totally unrelated to radiation. If you exposed those 100 people to a single exposure of 0.1 sievert or 100 millisievert of low LET radiation, which would be like X radiation, you would expect to induce 1 additional cancer. So instead of having 42 people out of 100 with cancer, you would have 43. So 42 people out of 100 are going to get cancer anyway from whatever reasons, either, like I said, genetic, environmental, lifestyle, and an exposure of 100 millisieverts or 0.1 sievert would increase cancer induction by 1 person. if the dose were decreased to 0.01 sievert or 10 millisievert, you would expect to see 1 additional case of cancer per 1,000 people. So does that make sense?
Nope.
Nope. Okay. What doesn't make sense about it?
That last slide that you were just talking about, I was trying to follow along, but I got lost.
Okay.
Exactly. That last slide.
Don't worry about that one, because typically we're going to talk about relative risk. But when you look at absolute risk, you're trying to really define it and say, okay, we'll have this many cases of induced cancer out of the 1 million people if they were exposed to 1 rad per year. And like I said, 10 people per 1 million would have cancer from a 1 rad exposure in a 1-year time frame. But like I said, it's so complicated, nobody really understands it. So we typically stick to the relative risk. Or you can use the example that I used at the end about 42 people are going to get cancer anyway at an exposure of 0.1 sievert or 100 millisievert. It would add 1 additional case. So here's the question. Do exams that we do give doses at that level?
Millisieverts?
100 millisieverts. All right, so let's think about it. There's a table on page 32 in your Statkowitz textbook. A chest x-ray is 0.1 millisievert. A C-spine is 1.5 millisievert. An L-spine, 3 millisieverts. An abdomen, 4 millisievert. A pelvis, 1.5 millisieverts. So does any general diagnostic exam typically give an exposure level of 100 millisieverts?
No.
No, no. So we still have to consider the linear non-threshold dose response, that theoretically any radiation can cause cancer. But we also have to consider that at doses below, what was it? Doses below 0.1 sievert or 10 rem or 100 millirem, we really don't have any conclusive proof that doses below that have caused cancer. So we need to protect our patients, but we have to understand that the procedures that we are doing provide very little exposure to the patient. So there is risk, but the risk of cancer induction is really not huge. And so we don't have to worry about our lifespan shortening. We also shouldn't worry about inducing cancer in our patients by doing a single exam. Now, what about patients that have multiple exams?
Maybe.
Maybe, that's right, maybe. Because the more radiation they receive, the greater the risk. But it's not something that you would worry about, particularly since the exam that you are performing might well save their life from some other condition. So remember you remember your dose limits, right? All those NCRP regulations where you've got all the different dose limits that you have to stay within. What's the patient's dose limit?
5 millisieverts.
Y'all agree?
Yeah, 5 sounds right to me.
That's yours. Patients don't have a dose limit. Patients have to consent to every exam based on the benefit of the exam versus the risk of the exam. So patients don't have a limit. They have to say to themselves.
It's basically like, hey, you're gonna die if we don't do this. You're gonna
Exactly.
get radiated. You might glow, but you'll be living glowing.
Well, look at it this way. Do I need this exam to save my life today? And do I need to worry about a cancer that I may get 30 years from now?
I'm gonna go with today.
I'm going with today. And which is what most patients would do. If I need to find out information that will save my life today and help to extend my life, I'm not really worried about a cancer that might come 30 years from now. But that's what every patient has to look at. So it's always benefit versus risk. There is no dose limit for the patient. All right, the last thing I'm going to do, I'm going to read off a list of 10 things. And I want you to tell me what you think is the riskiest of all these things. Has the most risk associated with it. All right. So, X-rays, pesticides, surgery, motorcycles, smoking, handguns, swimming, motor vehicles, electric power, alcohol,
Smoking.
Car accidents.
Alcohol.
Car accidents.
Smoking.
All right, so Marcus says cars, motor vehicles. Several of you said smoking. What does everybody else think?
Alcohol.
Swimming.
Alcohol, okay.
I'm going with smoking next, though.
You're going with smoking next?
Did you say motor vehicle or like motorcycle accident?
Well, motorcycles was a separate thing. There was motorcycles and then there was motor vehicles.
Motorcycle.
Wait a minute, but is this just for deaths or cancer?
This is just general perception of risk. Which of those things
Okay.
do you think is the riskiest?
Pesticides cause ovarian cancer, so that could be pretty risky too, or cancer.
All right. So, anybody else got any thoughts?
Swimming.
Everything. You're right. Everything has risk. So this was actually, I only did the top 10, but this was a list of things that they gave people. They gave to women. They gave them to the League of Women Voters. They asked college students, and then they asked members of professional societies to rank what they thought was the riskiest. And there were 30 different things, and there was a whole bunch of other things in there. The one that they thought was the riskiest was nuclear power. Nuclear power wasn't even in the top 10, so it wasn't on your list. In reality, it was the 20th riskiest thing because there were experts who had determined what really was the riskiest. So Marcus, you were correct. Motor vehicles
Woo!
for one risk. Smoking was number 2. Alcohol was number 3. Handguns were 4. Surgery was 5. Motorcycles were 6. X-rays were 7. Pesticides were 8. Electric power was 9. And swimming was 10. So
All right, Chad.
I only gave you the top 10. But,
Wow,
you know,
what pesticides would have come above x-rays. That's interesting.
yeah, interesting. So anyway, those are the rankings according to the real experts. And so the moral of the story is there's risk in everything. You just have to weigh whether or not the risk outweighs the benefit or the enjoyment. I would say if motorcycles is, you know, is something you would like to do, I would assume there's certain enjoyment in that. But it is relatively risky. But in general, people tended to put nuclear power as the riskiest when it was only the 20th on the list. All right. So I'm going to stop recording if I can.